Could we cue up the, oh, here we go, thank you. All right, so my second topic is, it's a bit of a shorter lecture. This is ocular surgery in uveitis patients, which I think may be the subject of some dread and some shivers from some folks as we go. But we'll try and cover some general concepts, talk about some things specific to cataract surgery and vitrectomies, how we use this as both diagnostic and therapeutic options, the role of immunosuppression in this, perioperative management, and how do you manage CME from uveitis around surgery. So I think most of the time when I call up a cataract doc, other than Matt Kruger, they tend to have this reaction when you say, I've got this case where I've had uveitis for 10 years and chronic macular edema, and they go, no, maybe there's someone else who can help take care of that, or maybe the university would love that case. But fortunately, we have a few really good cataract docs in town, including Matt, who helped to take on some of these really challenging cases for us. So you've heard me say this in the first lecture, there's no perfect recipe, right? But I think a few general concepts. There's the rule that the eye should be quiet for a minimum of 3 months prior to doing any surgery if it's elective, with emphasis on elective. If the pressure's 50 or 60, you have to break that. If you have someone who has LP vision and no view of the retina, you may need to do an emergent vitrectomy. But for elective surgery, minimum 3 months with everything calm. And in general, 6 months for cornea surgery if you can do it. If the PK is decompensating, you may need to do something sooner, but in general, you want to try and keep things calm for 6 months. You can do surgery in hot eyes, particularly vitrectomy surgery, but the eye does behave differently. The vitreous behaves differently during vitrectomy surgery when the eye is actively inflamed. Perioperative management with both immunosuppression and steroids. So we typically double up. We try and have the eye calm on one of the medicines that we just talked about in the last section. But we usually add in some amount of steroid with it, just trying to give you an extra buffer so that you don't have aggressive post-op inflammation. But despite that, eyes with uveitis, more things happen, and more bad things tend to happen in uveitis patients. So there's a higher risk of both intra-op and post-op complications, regardless of how good of a surgeon you are. Capsular tears, vitreous hemorrhages, RDs. The RD rate, just in general in uveitis patients, is 8 times higher than in the general population. So there's a lot of things that happen on, I think, a biochemical level within the eye that predispose you towards things like sublux lenses and RDs, much more so over the general population. If a patient has infectious uveitis, you can still optimize their medical management. We'll talk about how to dose Valtrex and Bactrim and things like that around surgery. But you have to inform patients this is going to be a little different in an eye with uveitis, and inform patients of the risks that are associated with that. And if that's something you're not comfortable with, then referring them to a tertiary center or folks who have experience in surgical management of uveitis is very helpful. A lot of our surgeries are both diagnostic and therapeutic. So quite often patients will come in and the referral says vision's been hand motion for 2 or 3 weeks, no view of the retina. Okay, what do we do next? So a lot of times it's just to get a view of the retina and see what's going on in the back of the eye. You can sample from the conj, from the AC, from the vitreous, and a lot of our patients are diagnostic dilemmas. The great line that Foster used to have, he'd say, you got a great case of something, we're going to do our best to figure it out. And while labs will help with that, a lot of times we need tissue, we need fluid from the eye to be able to help to solve these mysteries. And it's really helpful in patients who present with these 360 posterior synechii, perhaps an anterior capsular cataract, and they have an uncertain retinal status. So some things to anticipate, or I would say not to sweat, but at least to be aware of. Obviously a higher rate of complications due to synechii and membranes. You get much higher rates of PCO in uveitis. It's about 50 to 60% in most case studies. So when my patients are going for cataract surgery, I always tell them there's a decent chance you're going to need a YAG afterwards. You may need multiple YAGs afterwards. Ideally, if you can have a shorter amount of time inside the eye to minimize inflammation, But most of these complex uveitic cataracts actually take longer amounts of time, longer amounts of energy when you're doing the phaco. But doing informed consent for all these things in advance, I think, helps to set expectations and makes patients a lot more comfortable with the process. So in terms of pre-op planning, you want immunosuppression to be therapeutic. So we mentioned earlier that it's 2 months when we start any of these medications for them to be up and running. So you want that 2-month period before considering surgery. Again, the last flare a minimum of 3 months ago. Ideally, if you can wean off of the topical steroids when you start the immunosuppression, that's fantastic. But if patients come in, they already have a 2 or 3 plus cataract, I'm probably not going to wean them because that ship has already sailed, and if we can keep them calm for that couple months, it gets them to cataract surgery much sooner. We typically recommend either a periocular steroid or a little burst of prednisone around the time of cataract surgery. So even just a little STK at the time of the case if they're not a steroid responder. But if patients have more severe disease or more posterior disease, a lot of times we'll put them on 20 milligrams of prednisone 3 days prior to 2 weeks post-op. If they have infectious uveitis, about 10% of uveitis is due to an infection. Viral is the most common one, HSV and VZV. So we bump them up to therapeutic doses of their antiviral around the time of surgery as well. So the Valtrex will put them up to 1 gram 3 times a day. Again, that same 3 days prior to 2 weeks post-op. And with immunomodulatory therapy and these steroids, most patients are well controlled. But again, nothing's perfect in uveitis. You hope for the best and plan for the worst. So if they're a steroid responder, you can just do aggressive topicals afterwards because if the post-op pressure goes high, you can change that quickly, try and avoid STK. But a lot of times we've started with the advent of mini shunts and KDBs and CPCs. A lot of times we'll try and do a combination therapy at the time of cataract surgery. So if you're already in the eye and you can do an extra procedure for 5 or 10 minutes, and then we don't have to worry about steroid response for the next 5, 10, 20 years, that's really advantageous for a lot of patients, particularly if they have chronic CME, they need repeated injections or topical steroids to help try and manage that. If we can help buffer that at the time of cataract surgery, everybody wins. So a couple things, intra-op, obviously management of synechia you all are familiar with, iris hooks, Malyugin rings, anything to create less damage to the pupil. Synechialysis, typically we'll use a viscoelastic cannula. We'll start under a non-adherent area of the pupillary border, try and go away from the synechia as well, and then sweep laterally to lyse the adhesion. You can use Kugelin hooks. I've had to use retinal scissors when I was a fellow quite often if the synechia are really dense or long-standing. In terms of the iris, floppy iris is not uncommon, not so much due to medication, but because of paralysis and atrophy of the iris sphincter muscle. So you can try viscomydriasis, you can try intracameral epinephrine, but it's not uncommon in eyes that you wouldn't anticipate it to still require iris hooks or a Malyugin ring to be able to help maximize dilation. Trypan blue is your friend for fibrotic anterior capsules. Really difficult sometimes to separate the fibrotic membrane from the capsule itself. And so you can use scissors or even a vitrector to open the capsule if your regular techniques fail. So when I was a resident, there was always a big controversy of do we put an IOL in patients or not? And I think the paradigm on this has really changed over the last decade and a half. And if you optimize all these circumstances in advance, so immunosuppression, perioperative steroids, most uveitis patients can safely have an IOL placed at this point. If the surgery is emergent, if the uveitis isn't well controlled, okay, leave them aphakic, live to fight another day, we can put an IOL in months later. In pediatric patients, a lot of times the presenting symptom of their uveitis is the cataract, right? Especially in JIA, it's a generally silent disease. So a lot of times we'll have to expedite the cataract extraction because amblyopia is such a factor. We can give them an aphakic correction, use a contact lens, and you can put an IOL in much farther down the line. A common question we get is, can we still use a premium IOL? A huge part of a lot of cataract practices. And in general, I think in chronic uveitis, it's not a wonderful choice because future episodes of inflammation can compromise the visual potential. And the zonules, a lot of times we get much higher rates of dislocated or subluxed IOLs in patients with uveitis. But in select uveitis patients, you can do this. If they have recurrent iritis, it's all anterior, their macula looks pristine, they've never had posterior involvement, okay, yes, there is a role for it, but in general, just be a little more cautious. YAGs. It is really common to see post-YAG inflammation in uveitis patients. Normally you do your YAG, you typically don't see them back, everybody does fine, right? In uveitis patients, a lot of times they'll get post-op or post-YAG inflammation, and a lot of times the CME will get worse as well. So usually we'll do a week of Durezol at 4 times a day after the YAG just to try and buffer all those things so that we don't get the secondary complications. So we'll transition to what we'll call the Steve Petty section of the talk here, vitrectomies and uveitis. So Steve did a whole bunch of these on my patients for a number of years, and we'll talk about both diagnostic and therapeutic vitrectomies for a moment. So the most common reason to do a diagnostic vitrectomy is if you're suspicious for intraocular lymphoma. But we also use this in patients with infectious retinitis, so things like acute retinal necrosis, or uveitis that's just not getting better. We've given them steroids, steroid pills, steroid injections. We're still heading in the wrong direction. Okay, we've got to pivot. Something else is going on here. Vitrectomies can also be therapeutic. A lot of times the floaters and debris are so dense, you can't see the retina, you can't see what's going on underneath it. CME can be refractory quite often, and so removing the vitreous can help a number of patients, particularly if there's a tractional component to their macular edema. So here's a good example of this. This is a 66-year-old woman who had a 3-month history of her floaters getting worse in both eyes. But her vision was excellent. 20/20, anterior exam was normal. She had 2+ vitreous cells in both eyes, and these huge sheets of opaque vitreous inferiorly. Her FA looked great. There was no macular edema, no disc leakage, no retinal vasculitis, and there's a number of elements of this that should make you start to worry. So in general, patients with intraocular lymphoma, typically it's patients over 50, 55, but my youngest one was 31, so it can happen at other ages. And it's these sheets of vitreous where when you look in, you go, there's no way their vision is that good. So the vision's 20/20, 20/25, and your view you would think is probably 20/70 or 2100. So vision out of proportion, too good for the exam. And the FA looks good because this isn't really an inflammatory process, it's an infiltrative process with lymphoma cells, right? So you shouldn't see lots of retinal vasculitis, you shouldn't see a giant amount of macular edema. And so when the FA looks good and the vision is out of proportion good to what you would expect, you start thinking about lymphoma. So what do we do with this? Based on all these, we said, okay, we're suspicious. But a lot of times you're suspicious and it ends up years later being sarcoid or something else entirely. So we did a diagnostic vitrectomy in this patient. We removed about 1 ml of undiluted vitreous right at the very beginning of the case. So this is before you've put any saline into the eye. You're trying to get an unvarnished, undiluted sample. And you send that for cytology, 2 cytokines, IL-6 and IL-10, and I'll explain why those are important in a minute, and the MYD88 mutation, which is a newer test that we're able to do now through Mayo Clinic. And then you send the diluted vitreous from the cassette for flow cytometry. So it is really difficult to get lymphoma cells out of the eye. Getting a positive cytology is like shooting the moon or you're winning the lottery. You go, wow, we actually got that. But on average, it takes 3.2 surgeries in a retrospective case series to actually get a positive cytology for lymphoma. And the reason is these cells are incredibly fragile. So talking with your pathologist in advance, saying, here's exactly what we're going to do. We're going to hand deliver it to the lab, try and run your studies on this as quickly as possible. Even just putting them on ice for several hours is often enough to lyse the lymphoma cells, and you're unable to get a true positive. And where that's important, even if I'm suspicious for it, the neuro-oncologists aren't going to treat it until you actually have definitive cytology. And for that reason, the average time to diagnose lymphoma is somewhere between 12 and 21 months, which is an awful long time. 90% of intraocular lymphoma associates with CNS lymphoma. So the big worry is, I've got this brewing in the eye. Are they going to have a brain tumor in the meantime that's going to really change their life? So it's a masquerade syndrome and difficult diagnostically. So how do we try and sort all this out? The cytokines are really helpful. So there's two cytokines, IL-6 and IL-10. IL-6 is good. IL-6 associates with inflammation, so if you have really high levels of IL-6, you go, okay, my blood pressure is a little lower, this is probably not lymphoma. IL-10 is typically associated with lymphoma. So the higher the IL-10, the higher your level of worry. And if the IL-10 is over 400, it's nearly diagnostic for intraocular lymphoma. So Janet Davis at Bascom Palmer has some great data on this. But it's the ratio between the two. So higher IL-6, you go, okay, it's inflammation, I'm going to treat it with steroids and immunosuppression. High IL-10, even if you don't have positive cytology, you got to think, yeah, this is probably lymphoma. Like all those warning bells should be going off for you. You have to get a clean sample. So if patients come in and they're already on prednisone, they're already on Durezol, it's going to lyse those cells. You're not going to get a true positive. So here's a good example of this. That same patient we just discussed earlier, her cytology completely negative, no malignant cells whatsoever. But her IL-6 was 65 and her IL-10 was 1,045. We did an MRI of her brain, no CNS lymphoma. But I told her, look, I think this is lymphoma. I just can't prove it yet. And the frustrating part is then you have to wait. And so it takes usually several months for the vitreous cells to come back. But in the meantime, she had some headaches. We repeated a brain MRI. And sure enough, 2 lymphoma lesions that they were able to diagnose lymphoma from the spinal tap. So it's an ocular disease, but with potentially severe systemic ramifications. So knowing how to kind of approach these patients is really, really helpful. Second case, this is a 34-year-old male, comes in with a really acute onset, 1-week history, painful, red, severely decreased vision down to count fingers. Pressures are normal. He has some granulomatous KP, 3+ AC cells, some synechiae. But I can't see hardly anything into the retina. It just looks like soup in his vitreous. And no view posteriorly, tried OCTs, fundus photos, no view. So, okay, what do you do? So we put him on a day or two of high-dose Durezol every hour. We dilated him. We got his RPR back and quantiferon, and those were negative. But his vision had dropped now to hand motion, still no view, poor red reflex. So at this point, we decided for a diagnostic and therapeutic vitrectomy. And once we got in, we saw 360 degrees of peripheral retinal whitening, awful vascular sheathing, retinal hemorrhages, but the macula still looked pretty good. So we sent off the undiluted vitreous for all of our usual suspects, HSV 1 and 2. Important to send for HSV 2. If you have ARN in a young patient, over half of cases are due to HSV 2. VZV, CMV, and toxo. And then once all the vitreous was removed, you could apply PRP to the edge of the retinitis to try and wall it off. Put intravitreal ganciclovir in, start high doses of Valtrex, and sure enough, the HSV2 PCR came back 4 days later. So this is an important diagnostic tool when you can't see the retina or if you're suspecting retinitis. There's very few things that are going to go from 0 to 60 like this. HLA-B27 can, but retinitis certainly can do this as well. And the advantages of doing a vitrectomy, one is you know what's under there, you can get acute treatment to it, and you remove all the vitreous scaffolding. So the real worry in patients with ARN and infectious retinitis is that it can cause a retinal detachment. Published rates are about 50 to 70%, depending on which study you read. The disadvantages is this is a hot eye, and that vitreous is going to behave very differently. It's almost got a soup-like consistency, and you can get tears and detachments at the time of surgery. But as I mentioned, 50 to 70% rates of RD, but the RDs don't come quickly. Those are usually 6 to 8 weeks later. As the retinitis heals, the retina becomes almost like cracked mud, and then you get the breaks and you get the retinal detachments. So if the retinitis has spared the macula, a lot of these patients can do well long term. So our rate of over 100 cases in the past 15 years is only 21% in terms of developing a retinal detachment. And that's not just us. So this is the data from Texas Retina. Dave Callanan and Bob Wong published this. Patients who had an early vitrectomy versus no vitrectomy in ARN. And in their cohort, 25% had a retinal detachment. So much better to go in early, get the acute treatment in, you have your answer, and then you can hopefully prevent more complications down the line. We also use vitrectomy for diagnostic dilemmas. There's a ton of cases that come in and you just scratch your head, and it's the ones you wake up at 3 in the morning thinking about, going, what am I missing? What is not making sense here? So here's a perfect example of that. This is a 75-year-old gentleman who came in, a 1-year history, recurrent intermediate uveitis just in his right eye. He was hand motion, 3+ vitreous cells, and no view of the retina. But he had had 3 periocular steroid injections. He was a steroid responder, had an on-med valve, and no one had been able to see the retina since the valve was placed 3 months prior. We did the diagnostic vitrectomy, and about half of his retina had this RPE scarring and patchy whitening. It literally went right through the fovea. But it wasn't classic for ARN. Normally ARN is like chalk white, and this just didn't look as dense. So we did all of our PCRs. Everything was negative. Lab workup was negative. I said, well, it kind of looks like ARN. Let's treat with steroids and antivirals. And he did well. He got back to 20/70. His eye was quiet. But then 4 months later, the cells start to come back, and the vitritis is back. And I said, well, let's do the same thing. We'll give you antivirals and prednisone. Didn't work. So we took him back, did all the same studies. Everything was negative again. His IL-6 was high, his IL-10 was low, so we said, okay, it's not lymphoma. Unilateral disease, not responding to steroids. It's got to be some sort of weird infection. So there's 2 options in this case. You can send samples to Russ Van Gelder's lab at University of Washington, or you can send a sample to Proctor and UCSF for genomic sequencing. So we took the first option, and this ended up being positive for histoplasmosis. So it was a case of disseminated histoplasmosis in an immune-competent patient. I looked it up in the literature. There were 2 cases. And I said, okay, well, if this was the 3rd one, I didn't feel so bad about not catching that right off. But this is the part of uveitis that's humbling. What you think it can be initially and what you think it is sometimes the 2nd and the 3rd time may not be your final answer. So we presented this case as an option for diagnostic dilemmas. It was $500 out of pocket for the Washington lab, but it got him his answer. He had intravitreal amphotericin injections for a year, and it ultimately cleared the infection, and his vision was 20/50. We use AC paracenteses from time to time to try and get diagnostics as well. So this patient has unilateral iritis in the left eye for 18 months. She's 82. It's not responding to topical steroids. Her pressure was 45 at initial presentation, before any steroids. And you can see these iris transillumination defects from 12 to 3. And her cells just look different. Instead of being like your regular white blood cells, they're these little fine pigmented cells, just much more dense. And so this is viral uveitis without retinitis. And I think this is something that's finally gotten its way into the textbooks. It used to be called Posner-Schlossman syndrome. It was attributed to a lot of different things, but almost all these patients have HSV or VZV. And so you do an anterior chamber tap, and you're able to diagnose it. Most of these folks will need lifelong antivirals. This isn't, like HSV keratitis where they take some Zergan or they take some acyclovir for a couple weeks. They're typically on medications for years. You can also tap the anterior chamber for patients with a suspicion of lymphoma, sending for a lot of the same studies as well. This is CMV iritis. This is on the rise, particularly in folks who have moved from Southeast Asia. You get these little kind of ring-shaped KPs, and the only way to really diagnose it is from, again, an anterior chamber tap. And I know my time is running out. I got like 3 more slides. I'm almost there. Glaucoma surgery in uveitis. If you're doing PIs, put in multiple PIs and make them much larger. They tend to fibrose and close off much easier. Incisional surgery's come a long way. KDBs, mini stents. Used to be we just had Ahmed valves, but we're getting into a wealth of options now with glaucoma surgery. And the last thing I'll talk about is perioperative treatment of CME. So the big worry, you're going to do cataract surgery, you can do glaucoma surgery in a uveitis patient, their macular edema is going to go wild afterwards. And there's a lot of ways to deal with this. One is to put an Ozurdex in the eye. So this is a paper we wrote about 10, 12 years ago, that if you put an Ozurdex implant in within 1 month of doing cataract surgery, nobody had post-op macular edema. But if you did it more than a month, the Ozurdex tends to wear off, and your rate of macular edema is much higher. So if you want your cataract surgeons or your cataract surgery to be successful, put an implant in within a month. Most of these patients are going to do beautifully. In terms of immunosuppression, we want patients on immunosuppression for surgery. This is totally different from what you learned in medical school, what ortho would tell you. If I'm going to do a hip replacement, patient's immunosuppressed, they're going to get an infection. We don't get higher rates of infection in uveitis patients who are on immunosuppression, but you get much lower rates of post-op inflammation, macular edema, all the other complications. So in this case, you actually want the extra immunosuppression on board. There have been no documented instances of increased rates of endophthalmitis with using this. So in terms of take-home points, surgical management is a big part of treating uveitis. It's often some of the harder parts of it. Higher rates of complications, but if you kind of follow a lot of these paradigms, you can make things a lot easier. It's not perfect, but it's about minimizing risks and trying to do the best you can for patients. And this is a picture down in Telluride, Colorado, which if you have the chance to go down there in the southern part of the state is really wonderful at all times of the year, but this is about 2 feet of snow on Christmas Eve a few years ago, so a good place to check out in Colorado. So thank you all very much.
Any questions? We'll take one question. Ben, if you want to go on up.
So it's always super exciting when you're doing cataract surgery on one of these patients and you realize that the sneaky eye were most of what was holding the lens up, which I'm never afraid to leave a patient aphakic, but my question for you is, what is the ideal timing for a secondary IOL if you're going to do one, and what's the best place to put the lens?
Yeah, so a few options for that. You can put a sulcus lens in at the time of surgery. If you feel like the zonules are wobbly, you can just put a sulcus IOL in at that point. Usually I would wait a couple months for the dust to settle, and then live to fight another day, go ahead and put it in. You can do scleral fixated lenses with the Yamane technique. We have a number of patients who have done beautifully with those. You can put a sulcus lens in as well. I try and avoid anterior chamber lenses. I think just the rate of complication is too high, but I think the scleral fixated IOLs over the last probably 5 years have revolutionized how we approach these.